can speak fluent Arabic, but as you know, our conference is English official language. So we have to talk in English. I hope this is okay with you.
Absolutely.
Okay. First of all, we are very happy here in this conference hall. Almost 600 people are all excited about having a teleconference with you. So we are happy and welcome you here in Cairo, in your country, actually.
Well, first of all, can I say thank you very much for inviting me to talk.
Yeah.
I can only see you, I can't see the audience, but I know that you've got a very distinguished group of people, and it's a real pleasure to be able to talk to them. So thank you very much.
Okay. Let's start our scientific talk with you now. We want to get more experience from you regarding several issues. Yeah, we are very well known in UK, but we need to know more and more about your experience in practicing IVF in UK. Let's start with our main common complication in Egypt, obesity. And we know that you are specialized in obesity with infertility. So could you please illustrate how the impact of obesity on IVF outcome or on pregnancy outcome regarding patient infertile? What do you do in UK, actually?
Well, the question here is that in the UK, as you are and we all are in Egypt and everywhere, we know about the obesity epidemic. And as we've learned more about the obesity epidemic, we've learned more about the reproductive consequences. Okay. So we know about the problems associated with obesity and reproductive medicine. We know that these women have a higher problem or higher prevalence of problems with infertility. We know that they are much more difficult to stimulate and they need a high dose of drugs. We know that their response is not ideal, like patients with a normal BMI. We then have another problem, particularly here in the UK, where a large amount of our service is nationally funded. Where these patients then, if they did get pregnant, they then go on and see our obstetric colleagues. They are then faced with the impact of the complications of obesity, with the obstetric impact, from gestational diabetes to macrosomia to all the problems associated with this. And for this reason in the UK, we have particular restrictions on the BMI of patients who would be treated with fertility treatment and IVF in particular.
My question, do you accept any case, whatever body mass index in UK to do IVF, or you have restriction?
No, we do not. There's some variation across the UK, depending on where you are and what sort of government funding is available in that area. But whether the patient is funded by the government or whether the patient is paying for herself, no one with a BMI of above 35 would have treatment in the UK.
35 body mass index is the cutoff value. Is our seal. Is our seal.
We would not eat, for the reasons which I've explained to you now. First of all, the government will not fund patients where they know that the success rate is lower. They will not fund patients where they know that they will need more drugs and the success will be lower. And then they will not invite complications in the obstetric aspect when they get pregnant. And similarly, patients who pay for their treatment in the UK are treated in a very similar way, although we allow sometimes a little bit of a higher BMI. But either way, BMI 35 would probably be the maximum you would find any patient. So we don't really treat patients who are morbidly obese in the UK.
Okay. Today, this morning, we were talking about IVF, and the key of success is the teamwork. May I ask a very straight question and very frank question? Who is going to do embryo transfer in your clinics or in your unit? I heard that nurses are doing the embryo transfer. Is it okay? This is right? Is it correct?
Yes. We have to say there is very much a multidisciplinary approach to what we do. And that involves in both clinicians, nurses, counsellors, so several people. Now, who does what procedure will vary across the units in the UK. So, for example, where I work, which is in the Royal Hallamshire Hospital in Sheffield, the nurses do a lot of the embryo transfers, they do a lot of the ultrasound scans, but the doctors will do some embryo transfers, not all of them. This is shared between us, and they would do the debt collections definitely by the doctors. Now, we have a very set standard for practice. So we have, for example, the British Fertility Society provides standard training module for embryo transfer. So whether it's the doctor or the nurse who's doing it, they will go through that program.
Okay.
So everyone
they all go to the program. It's an educational program.
Everyone to do an embryo transfer would go through that standard training. So they would all do it in a very similar way. But yes, in our unit, a lot of the embryo transfers are done by the nurses. The consultants or the doctors would interfere when there's a slightly more difficult embryo transfer, perhaps difficult access to the uterus, someone with several failed fertilizations before. But the nurses do a lot of the embryo transfers. And they have very...
And the patient, the woman, does not become hesitant or worried or something like this?
The patient, at the end of the day, accepts that we work in a multidisciplinary team. And the culture is slightly different. So our units in the UK, where the nurses would do the egg collections as well, although there's not many units.
Egg collection?
Egg collection as well.
So what the doctor usually do?
We don't do that here, and it's not a wide practice. But the embryo transfer, the IUIs, all these things are by either the clinician or the nurse, provided they've had, the standard training for this. So not any doctor and not any nurse would do it. It has to be someone who's senior, someone who's experienced, and someone who's been trained. And we have to demonstrate consistently our individual success rates. So every 3 months we issue our pregnancy rates per operator.
Okay.
And if someone is found to have a lower pregnancy rate, then they have to be addressed.
Okay.
So the issue here is not who does the embryo transfer. The issue is that we don't have someone who's an outlier with a particularly low pregnancy rate compared to everyone else in the unit. And this is continuously looked at.
So you have a continuous process of evaluation, audit.
Continuous audit, prospective audit for pregnancy rates, all aspects of the treatment, including who does the embryo transfer.
This is very interesting to us actually to hear that we have an audit, continuous process of auditing.
And what we find, Hisham, is regardless of whether it's the doctor or the nurse who does it, the person who does more embryo transfers is the person who has the highest pregnancy.
Yeah. So it doesn't matter whether a nurse or a doctor.
No, it's the pregnancy rate which counts, because at the end of the day, we look at our success as a unit, not as an individual. But if an individual in this unit has pregnancy rates which are very different, then we have to address that. But at the end of the day, they all have to be within the same average.
Okay, let's be practical for ovarian stimulation, which is your most common protocol for stimulation, the protocol.
I've worked as a consultant in UK in 2 units, one here and one in Scotland. There's always going to be variation across the UK.
Yeah.
But what I can say is Sheffield, where I was trained and where I work at the moment as a consultant, is one of the first units in the IVF to be almost completely dedicated to an antagonist protocol. So we are one of the units which developed the antagonist protocol. Since we started here in 2000, we've continuously looked at our results, looked at the L8 surge, and we've changed our protocol about 4 or 5 times in the first 5 or 6 years where we were doing it.
Yeah.
And I can say that we're one of the most experienced units in the UK with practice of protocols. We do long protocols. We do short protocols, which some people would call a flare protocol, but this is not the usual. The most common standard protocol is an antagonist.
Antagonist?
Yeah.
Actually, it is well known that the long protocol is the standard protocol. So it is now the reverse in your situation.
I think the standard protocol is whatever works for that particular unit. Yeah. So, for example, I used to be a consultant for some years in a unit in Scotland, and Scotland has many islands which are very far apart. So patients cannot come at short notice for egg collections. Antagonist protocols are very inflexible. You have to be working at least 6 days a week.
Yeah.
The patient has to be available at short notice. You cannot sit on a follicle very long if it's mature with an antagonist protocol. You need to do your egg collection. So in Scotland, for example, it was very difficult because patients would, for a day or 2, come over to the unit. So the standard protocol was a protocol. I think if a unit is using a protocol and this protocol works for them, this should be their standard protocol. There is no reason to change the protocol. We have always started with an antagonist protocol and we've become quite good at it. It's our standard protocol. But that doesn't mean it's better than the long protocol. It has its disadvantages.
Okay. Could you please allow me to open questions for the audience? Could they ask you a few questions, because I am the one asking everything now. So I would like to open question to other people. It's okay. Is anyone interested to ask Doctor? Yes, please come here. You may not see the doctor, but you will hear his voice very clearly, Mustafa.
Dr. Mustafa, nice to talking to you. Would you give double dose of the antagonist in patient with obese?
No, we do not modify the dose of any of our stimulation regimes apart from the FSH for patients who are obese. And we've audited our results. There is no difference in the LH surge between the patients who are obese or normal BMI. So we don't modify the dose of the cetrotide or the antagonist, no. Only the FSH.
Only the FSH. Okay, so Dr. Wala Deeb with you.
Hello, thank you
Hello.
for your presentation. And I would like to ask you, for your antagonist protocol, and you found the size of the follicle is more than 18 millimeter, and you just give 2 or 3 shots of the antagonist. Are you going to give the patient your HCG or what?
So can I just ask, what do you mean by giving 2 or 3 shots of the antagonist?
After 3 days of the antagonist, you found the size of the follicles is more than 18 millimeter, and the endometrium is more or less better. Do you give the HCG in this case? Or you...
It is not the number of days of the antagonist. We start the antagonist on the 5th day of the treatment of the FSH injections. So we're talking about day 7 of the cycle. Now, the patients never are ready before day 8 or day 9 of the stimulation. So regardless of how many days of antagonist we give, we trigger the patients when the follicle is about 17 or 18. And this is the problem with antagonists. If you leave the follicles too much, you get a detrimental effect on the endometrium.
That's my point, yes.
Exactly. So unless you're willing to measure progesterone and weight before you do your trigger, we usually trigger at 18 millimeters maximum.
And do you have an increased number of M1 oocytes, M1 embryo in the antagonist protocol?
No.
The same. Thank you.
Dr. Hamad Sufayan from Saudi Arabia with you.
Thank you, Doctor.
Thank you.
How thin is a thin endometrium, and when would you do or cancel transfer? Do you have a...
Sorry, can you say that again?
How thin is thin endometrium, your cutoff point? Will you transfer at 6 millimeters, or would you freeze and transfer later?
Well, it depends on whether we're doing a fresh or a frozen cycle. Now, we have good evidence from a frozen cycle that you don't get many pregnancies if the endometrium is less than 7 millimeters.
What about fresh?
In a fresh cycle, we don't have a cutoff for the endometrium because we look at both the endometrial thickness and the endometrial pattern. Now, in practice, you're never going to find an endometrium less than 6 millimeters unless this patient has an abnormality. So if we found a patient who has an endometrium of 5.5, 6, this is very rare. But if we find an endometrium which is slightly thin, but it has a normal tri-laminar appearance, we would probably be reassured. But if we have a patient who has thin endometrium, that it looks interrupted, it does not look normal, then we would cancel and we would do a hysteroscopy to proceed any further with treatment.
Lovely, thank you.
Okay, may I ask you, Mustafa, what do you do for a negative TISA?
So if someone has a PISA and a TISA and it's negative,
Yeah.
okay, we would proceed with an open biopsy.
And if open biopsy is negative?
And open biopsy, well, this is then slightly difficult in the UK, and it depends on who is paying for the treatment. Because we do find, although the evidence says that there is no difference between TISA, micro-TISA, and all these things, we do find in practice that micro-TISA sometimes gives you sperm in patients where you can't get it with an open biopsy. Now, the number of people in the UK, urologists, who do micro-TISA is not large. We have about 3 or 4 people across the UK. And we then would offer the patient, and they've been even successful with Klinefelter, about 40% recovery rate in patients with micro-TISA. If I have a patient in the beginning who is Klinefelter or has a very small testicle, and I'm concerned, and I'm going to do one procedure for them, I might refer them straight to micro-TISA. But if I have a patient who the TISA fails and open TISA fails, I can refer them for micro-TISA. The problem here becomes the funding for the. If the patient is paying for their own treatment, then they have to be aware they might pay up to £8,000 to have this done. Some patients in the UK would then prefer not to have a micro-TISA and to go ahead with treatment we wouldn't do in Egypt, which is treatment using donor sperm.
Okay.
So there's a lot of variables involved here, but from the medical point of view, we do sometimes offer these patients micro-TISA, but we refer them on because not all surgeons here do the microteaser. There are a few
Okay, my last question to you about what's called the cross-border reproductive medicine. That means people move from country to country to get treatment. Do you face this in UK or it is just in other places?
We face this in the UK, but usually not for the patients having fresh IVF with their own sperm or with their own eggs.
Okay.
We a lot in the patients having donor treatment. So patients having IVF using donor oocytes or donor sperm treatment, or patients who want to have treatment at a higher maternal age. So we wouldn't treat anyone here above the age of 45, particularly with their own eggs or even with someone else's eggs. So the restrictions in the UK for treatment using donor gametes sometimes a little bit longer. But some patients leave the UK and go and have their other European countries. But for normal IVF, I do, you do, and everyone else in the audience do, we don't really have cross-border IVF. We have here, and we're able to treat patients.
Okay, Mustafa.
It's from abroad to treat. So, but this is different.
I got in my mind another question actually for you, but it is a personal question. Do you like to get back in Egypt, or you are just settled there and you are going to live there for good? This is a personal question, but it just come in my mind.
Question: who doesn't love his own, Egypt? Okay, and I think the way forward now is that we are all having to be very flexible. The world is a very small world now. It doesn't matter whether you live in the UK, whether you live in Egypt. I come over and I do courses in Egypt, and my colleagues come over here, and we all work together.
Yeah.
The bottom line is that Egypt has to benefit from anything that we learn to do. And the same thing, I go to meetings and I learn from you and I learn from my other colleagues, and we exchange ideas. And maybe if we all sat in the same place, we wouldn't exchange so many ideas. So this, of course I would love, and I wish to do more and more with Egypt.
Okay, thank you, Mustafa. It was a very nice meeting with you, actually. I was very happy talking to you.
I'm very happy. Thank you, and thank you for all your audience.
Greetings to Mona and the kids.
Okay,
Bye-bye.
bye-bye.
Bye. Okay.